Good afternoon. Thank you very much for attending this session. My name is Brian Davis, and I am co-chairing the program along with Dr. Razvan Galalae. The title of this program is Clinically Proven PEG Hydrogel Spacing for Prostate Radiotherapy. I will be presenting first on minimizing rectal dosimetry with hydrogel spacer, talking about 3-year clinical results with a trial in the United States. Then Dr. Galalae will take over, and he will present on hydrogel as a game changer in high precision prostate radiotherapy. So here are disclosures. This is traditional for us to do in these talks. And here's an outline of my presentation. I will be focusing on the clinical trial results in the U.S. randomized phase 3 trial recently published by Dan Hamstra and presented at the ASTRO meeting in Boston last year. And other experiences, including the German-Australian experiences, unfortunately we don't have time to cover in my presentation, but I will briefly describe the procedure and also our experience with it. And we will have some case examples, which we call good, bad, and ugly. So in prostate radiotherapy, whether external beam or brachytherapy, the rectum is the dose-limiting organ. And I'd like to ask for a show of hands, how many here are radiation oncologists? Okay. How many here at your center either do fiducial marker placement or any type of prostate brachytherapy, HDR, LDR? So 2/3 of the audience, at least, 3/4. So I'm going to start off by putting it this way. If I were only to show 2 slides on this topic before we get into the nuts and bolts of it, it would be as follows. Here's the first one. So this is the results of the randomized trial, where it's a 2-to-1 randomization of 222 patients treated at 20 centers in the United States. Everyone was treated to 7,920 centigrade and had scans before and after hydrogel placement. And there was central review and planning at Washington University, which is a key site in RTOG clinical trials. And essentially, we see marked reduction at all of these critical DVH parameters that are used, particularly the V70. This included a 50% reduction in V50 and 80% reduction in V70. So this is clear. And then for anyone who has experience with prostate ultrasound, the imaging with this procedure is essential. If you can get a good prostate image and you're able to hybridissect with 2 to 3 cc's of saline and imaging the prostate well, then this is something that you should be able to do. Now, normally we visualize this under sagittal, but here's an axial view showing with proper needle placement and proper injection of the hydrogel that you get this separation. And in our experience, we're able to do this approximately 98–99% of the time, either if there's poor imaging or you're not able to inject the saline is when you would not do it. So now looking more closely at some of the background of this, most of us are familiar with this experience. I happen to be very familiar with this experience because this is data where I trained in the era of dose escalation prior to randomized prospective trials and favorable risk prostate cancer patients with 5–6 years of follow-up. It was shown that by increasing the dose from 65 gray to 80 gray, you could have a marked reduction in PSA relapse, PSA failure. And then following this, there were a number of randomized prospective trials with RTOG 0126 is the largest of these trials reported to date, given its sample size of nearly 1,500 patients, as well as its enrollment of only intermediate risk patients. This is the trial which one might have considered to show a survival advantage. But we did see in some studies local control advantage, salvage with androgen deprivation, free survival, and distant metastasis-free survival. But this came with a cost, and here is reduction in rectal toxicity with the use of IMRT. And going back to this series of different clinical trials, randomized prospective trials, and focusing on this column, you had statistically significant increases with the high-dose arm of grade 2 or greater rectal toxicity. And many of these are fairly recent experiences and did include some IGRT, but nonetheless, you have rates that are anywhere from 16 to 13% in these multi-institutional trials, and this is not trivial. Likewise, with low dose rate brachytherapy, you have the situation where if you give too much dose to the rectum, then you will have a risk of hematochezia grade 2 plus. This is our experience at our institution looking at improvement of the learning curve in terms of rectal V100 exposed to number of cc's. The goal is to keep it below 1, and this is from 1998 to 2005, and if we extend this out to 2017, these are very low, but still we have concern about rectal toxicity. And here is a patient from 2000 that unfortunately experienced a rectal ulcer. And then I asked the question, how many patients will you spend 5 or 6 extra minutes putting in a hydrogel spacer in order to prevent this from happening, minimize this from happening? So here is a summary of the randomized prospective trial that I discussed with 2-to-1 randomization, hydrogel spacer to no spacer. It was conducted at 20 institutions. And last month, the trial results were published and also presented at ASTRO last September. This prospective trial was single-blinded. Patients had fiducials placed, and they didn't know whether they would have the hydrogel spacer placed. And generally, it was found that it was easy to apply, it was well tolerated, and as shown previously, it shows a significant reduction in rectal dose. The benefit was seen at 15 months for bowel toxicity and other quality of life metrics. Here's a list of the 20 different centers. Some are private practices, others are universities. And once again, here are the data with the resultant reduction in the DVH to the rectum. Also turned out that there's reduction in the penile bulb dose, which is a potential added advantage. So now let's talk briefly about the method of application, the technique. At our institution, we've actually set it up where we have radiation oncologists that do it, urologists that do it, and for our external beam patients, for a number of years, it's been our interventional radiologists that have placed the fiducials. What's key to that practice is that we have a small cohort of ultrasonographers who work with placing the fiducials, who also come to the procedure room and doing prostate brachytherapy or cryotherapy. And it's a small key group of individuals who work with all 3 different disciplines in doing this. And we are integrating the hydrogel spacer in our photon practice, we have integrated our proton practice and also brachytherapy, primarily LDR and even with HDR. Excuse me. So the package, when you go into the operating room, you open a package, and there are 2 vials, a powder, a needle, and some connectors. There are 2 solutions, an accelerator and a precursor. When mixed together, they cross-link to form a soft hydrogel. Here is one of the vials, and with the powder. And then this is injected and mixed. And usually we have 2 physicians that are doing this. One is preparing this, and the other is actually taking this needle. It's an 18-gauge needle, 15 centimeters long, marked in this fashion so that the bevel is down, and there's 10 cc's of saline. There's a syringe holder, there's a plunger cap, and there's a Y connector. And importantly, there's no latex involved with this. And then when this is all done, you have these 2 solutions connected to a Y connector. You don't want to inject this prematurely or it will freeze up in the Y connector. But this is how it looks when it's assembled. And while this is going on, it's easy to identify a suitable entry point, particularly after brachytherapy, by angling under sagittal ultrasound with the syringe filled with saline. So here is a picture of the sagittal ultrasound with the needle coming in an angle such that you're above the rectum and below the prostate. And then you inject a couple of cc's of saline. This is a critical part. You have to be able to visualize this. And if the saline goes in easily, and you can notice it on sagittal and axial ultrasound, then you're free to proceed. Thanks. And then when you're ready to inject, you inject over 10 seconds. But one thing is, if you can't see it, you're not going to inject. And if it is particularly hard or difficult to inject, you stop it. But the vast majority of the time, you're able to do this. And once again, showing how this is injected. There's a little bit of air here, and this is something that dissolves over 6 months. And this is the type of thing that you're looking for. This is a case which our typical range of maximal separation is 5 to 13 millimeters. But as you can see, this is post-brachytherapy. Here are some seeds. Here's the prostate. Here's the rectal wall. And this one was 18 millimeters, actually more than we would need, but no problem in doing this. And then we will do the MR planning. This shows up on T2, and we only do T2 and lava flex, a very limited MRI to see this. So, of course, here's the prostate, here's the hydrogel spacer, and here's the rectum. I want to draw your attention to a recently published paper. It's online, and looking more closely at spacer distribution. This is related to the clinical trial. It's 149 patients published out of the University of Washington, where they looked at this very analytically in terms of the geometric analysis, because the types of images that you'll see at conferences, here's this perfect placement of the spacer, but what happens if it's not 100% perfect? And what they did is they came up with a scoring system. First, here, this is it perfectly symmetric, slightly asymmetric, or really asymmetric? And also, if you're not having good imaging or you don't have a lot of experience, what happens if there's some rectal wall injection? So 6% had some rectal wall injection, but didn't correlate with any detriment in quality of life. And in terms of the symmetry, nearly half were symmetric based on their scoring system, 51% were slightly asymmetric, and only 1% were really terribly asymmetric, such that it wasn't useful. 6% of the patients total, as mentioned, had some rectal wall injections, but there were too few events in order for this to be clinically significant, and of all these patients, there were no ulcers or fistula in the study. So their conclusion is that in this study, asymmetry of hydrogel was found to be common. However, all but the most extreme asymmetry still resulted in significant rectal dose reductions. That's what we see at our institution. And additionally, rare rectal wall injection was observed, but was not correlated with patient complications. Now I want to talk about the experience at our institution. We've been doing this nearly 2 years. And 167 cases. We started off first with doing external beam cases only, and a very small cohort of interventional radiologists learned how to do this, and then we did the cases sparingly, but found that it was going very smoothly. We've done 55 proton cases and 89 IMRT cases, and some of these have been combined with brachytherapy. And then we started doing it also in the procedure room with brachytherapy. And we have, of all these cases, one case was aborted due to poor ultrasound imaging. So what are the logistics of this? When do you do this? So if you're doing this with external beam or protons, in our center the spacer is placed in interventional radiology, but that can vary depending on the center. Certainly if a radiation oncologist is skilled with doing prostate brachytherapy, then the radiation oncologist can do it, or likewise the urologist. So the spacer's placed, then patients go for MR, and then we use MR-CT image fusion for planning. If we're doing a low-dose rate brachytherapy, we place the spacer at the end of the case. And I'll comment on this for those of you who I know are many that have experience with brachytherapy. How difficult is this to do? Well, I'd say it's more difficult than placing fiducials, But if you're comfortable with LDR, HDR brachytherapy, this is definitely less difficult. And if you just follow the rule that if you can't visualize it, you don't do it. If you can't push the solution in, you don't do it. You're going to end up doing it over 98% of the time. Now, if you're doing it combined treatment with LDR and external beam, what's the order that you do it? We do the seeds first, so that at the end of the brachytherapy procedure, we put the spacer in, and then we proceed to external beam radiation therapy. And in that situation, we tend to use palladium so that we can move to the external beam radiation therapy. We've also done LDR proton combination, but this is a little bit more of a challenge, because you don't want to do the brachytherapy first with all the seeds in the prostate when you're delivering protons. So you do the spacer first, you do the protons, and then you do the LDR. But the real question is, can you see the spacer under ultrasound guidance when you go into the operating room doing the prostate brachytherapy boost? And in the number of cases that we've done, we've always been able to see it on ultrasound. But the urologist that I work with is skilled at MR, ultrasound image fusion. We have that as a backup if necessary, but we haven't had to use it. And we've also done it with HDR and external beam. But essentially, we're working to integrate it in each and every case, just to afford us that extra margin of error and reduce rectal DVH. The other thing that we are planning within the coming months is to do a 5-fraction SBRT type with protons. And with the spacer in place, we are a lot more comfortable in using multiple fields, particularly anterior fields. So here is a proton study that's actually published this week at PT-COG in Tokyo. And here's an example of some treatment fields that we are routinely using now with protons, where we're using anterior obliques, and we still do use some lateral obliques, and here is where the spacer's placed. And with this, we feel a lot more comfortable if there's range uncertainty that we're not going to deposit extra dose in the rectal wall. Turns out also that the folks at Mass General Hospital have done exactly the same thing, and the title is very self-explanatory. Hydrogel rectum prostate spacers mitigate the uncertainties in proton relative biological effectiveness associated with anterior oblique beams. This is also recently published. So, are there situations where it's not pretty or it's ugly? And we have at least half a dozen people that are doing this at our institution, and here's one, and it's also in that article out of Washington University, where this particular patient had spacer injected between the prostate and rectum, but also had some injected in the prostate itself. And what was the result of it? The patient was treated with IMRT and really didn't complain of anything. Here's another one where we have inadvertent rectal wall injection in a patient with prior cryotherapy. We will treat these patients. This was done in our interventional radiology department, and patient developed temporary rectal discomfort and had some urgency with bowel movements, but this resolved. So what are some of the observations that I have regarding the hydrogel spacer? It's markedly improved rectal dosimetry and reduced radiation-associated toxicity is definitely observed with the use of the spacer. Radiation oncologists, urologists, and interventional radiologists with prostate ultrasound expertise are the appropriate clinicians to insert the spacer. And emphasizing adequate visualization of anatomy on ultrasound imaging at the time of gel placement is essential. Only eject if the hydrodissection works. Symmetric placement of gel is desired. Asymmetric placement remains nonetheless very useful. Misplacement of gel in the prostate, rectal wall, periurethral location, or adjacent vasculature, in our experience, has not resulted in any long-term complications. And we recommend for somebody who's starting this to have their cases proctored, at least for 3 to 5 cases. It's helpful when you're starting this. And this concludes my presentation, and now it's my pleasure to introduce Dr. Razvan Galalae, professor at the Christian Albrecht University of Kiel and department head of radiotherapy at the Evangelical Clinics, Gelsenkirchen.
Okay. Thank you very much, Brian, for the kind introduction. Thank you for Augmentics to invite us to give these lectures and to share our experience with our fellows. And let me start my presentation with the statement that we in Europe welcome as anti-protectionists our American fellows. Okay, so my disclosures, Augmentics and SciS Diagnostics are supporting our phase 2 trial. Thank you very much for that. I would like to start my presentation by discussing this systematic review of randomized controlled trials. This is the collective knowledge of evidence-based medicine in prostate cancer, published in European Journal of Cancer in this volume 51 in 2015. This is a good read, I would recommend you, and it details 36 randomized controlled trials. You see here on this general overview, of course I will not discuss them with you all the details, but I just want to point out some important comparisons. So you see here that the comparison between radical prostatectomy and brachytherapy was isoequivalent, so there is no proof in randomized trials that radical prostatectomy is better than brachytherapy. Then the addition of brachytherapy to external beam as a boost, as Brian mentioned, also is extensively used, but it was proved in randomized trials to be beneficial. And third point is the addition of hormones to the combination of external beam and brachytherapy was not beneficial. So there was actually no difference. Dose escalation in terms of external beam alone was, of course, beneficial. And it was a price to pay for this 10 gray more dose escalation in the range of grade 2 and higher toxicity of about 14%. And this finding was actually identified by the American trial, one of the 6 randomized trials performed, and was published in Red Journal in 2002. And you see here the clear dependence of the proportion of the rectum irradiated with a dose higher than or equal to 70 grays, so the V70. And Brian showed also in the randomized trial with the gel that extremely, the V70 was really very much reduced. You see here that it's important to reduce the V70 as much as possible, but if we go over 20%, the toxicity becomes really extreme, so this should be avoided. And of course, this danger, this risk is much higher in EQD2 times EQD3 if we go to stereotactic or hypofractionation. That's clear. Okay, I don't want to show all the randomized trials with brachytherapy, just this one. This is the recent one, most recent one published or showed in the ASTRO meeting 2015 in San Antonio with a clear advantage of brachytherapy boost. And the comparator was IMRT modern technique 76 gray. So you see here extremely good results of 82%. And this remember this figure is actually exactly the figure we have achieved also. So just a few words on technology. First, external beam and then brachytherapy. So we really have improved in external beam technology, especially by IMRT and VMAC technology, which can be used now for hypofractionation and for stereotactic treatments. And important is not only the conformality and the high precision, but also, as you can see here, the very high dose rate up to 24 gray per minute, and the possibility to use IGRT and, for example, with this catalyst CRAD system, surface-guided techniques, which are important even for pelvic irradiations. What are the brachytherapy advantages in general over external beam? Of course, brachytherapy is very conformal because we treat smaller treatment volumes than in external beam. There is no need to enlarge the CTV to PTV. Normally, no margins are added, or very minimal margins are added. And the irradiated volumes, so the low-dose volumes, are almost zero. That leads to low integral dose, better sparing of ORS, and low risk of secondary cancer and toxicity, at least theoretically. But of course, there are many ways to go to Rome, no? And it represents an ideal solution, in my view, to address the moving target problem. So we have introduced HDR brachytherapy for prostate cancer back in year 1986. Published first the first long-term results in the beginning of the Nuller years in a Red Journal, and then the technique started to proliferate. Also in the USA, we had good cooperation with William Beaumont Hospital, the group of Alvaro Martinez, and also with Jeff Demanis, for example, in California. We have updated to 15 years outcomes our publication in 2014 and published that in Journal of Brachytherapy. And if you review this first publication in 2002, see here that at that time this BNED survival rate was really a revolution, because you have to think that the patients who were treated have been treated in the 1980s and the beginning of 1990s, so we just experienced the transition from Cobalt to first Linux. So it was more a sign to the urologists that we can cure prostate cancer. And you see here that the GI grade 3 toxicity was very good. The gastrointestinal toxicity was acceptable, even from today's perspective, but was higher because the technique we have used was a peripheral loading of the needles. So this is the 15 years paper with a unique pool of patients at follow-up up to 22 years. And as far as I know, this is the only paper with such an extended follow-up. Then we have introduced in 2003 the intraoperative adaptive technique. And let me show you that a little bit more detailed. So that opened a new era of possibilities for us, especially to do a focal integrated boost, as you can see here. So we can enhance the dose in a special area of the prostate, and the limits of the organs at risk or structures at risk remain the same. See here? Especially important later on, you see, for salvage. So when comparing the 5 years results of this adaptive brachytherapy technique to the pre-planned protocols, you see here we have reached in the high-risk cohort, 500 patients treated, a high difference of 20%. And this is what we basically also see in gynecological brachytherapy between adaptive brachy and pre-planned brachy. But we have also identified a very interesting early predictor for biochemical control, because this is a problem in salvage that you wait too long sometimes until the clinical relapse occurs. And we saw in our data, these 500 patients at long term, that the nadir PSA at 8 months, so the lowest PSA within 18 months after treatment, this, very nicely distribute the patients in these 4 categories. And the category A, as you can see here, is real cure by reaching, so these are the patients reached a nadir of 0.5 nanogram per milliliter. And this is our strategy right now to don't wait for relapse, but to go to, for example, PSMA PET and look to the local situation. So now I would like to share with you the very preliminary results of the modified kill protocol 3 with the hydrogel. And because Brian showed in a perfect way the technique, so I can go faster through this is a prospective study aiming for 100 patients. 2 MD projects are related, and a PhD project. And I would like to acknowledge my colleagues Tim Petri, Stefanie Föcking, and Rodrigo Hepp for being so supportive and working very hard for this protocol. We passed the ethics in October 2013 in the University of Münster. This is our local ethic commission. First patient was enrolled in March 2014, and I show you now very preliminary results of the first 30 patients. So this is what was different than, let's say, studies performed by urologists. We counsel the patients always in an interdisciplinary team with the urologist, so what we call shared decision-making counseling. It was also a research project of 3 universities, Kiel, Hamburg, and the Medical School of Hamburg. So after informed consent, counseling for anesthesia was performed, and implantation and the MRI planning. So the procedure description I don't want to repeat, just to tell you that, of course, we used the brachytherapy setup. No? That's clearly an advantage to do that. And as Brian said, I think for brachytherapy specialists, it's not a big deal to implant the hydrogel. And the main point is the live ultrasound, and to do the hydrodissection first and see in the live ultrasound if it's going well, and then inject the real gel. So this is what you saw already. Okay, then we measured in MRI, but also in transrectal ultrasound, the spacer, the distance reached. This is an example in MRI. But our main measurement was transrectal ultrasound. As you can see here, this is a gel injected with 14 millimeter distance. So what is the entire procedure for those of you not doing brachytherapy adaptive? So we implanted the gel up front as a single procedure 1 week before or 2 weeks before, in order to make sure that the visibility in transrectal ultrasound is not altered, because we saw that if we do that in the same procedure, that would be not so good. And of course, if you do LDR brachytherapy, it's fine to do it afterwards, no? Because the treatment goes on for 3 months, but in HDR, you should do it upfront. So the next step will be transvolumetry, then inverse planning of needle geometry and calculation of the first visual plan. Then the needles were implanted according to this needle geometry, and I will show you that we have changed our implanting strategy in these cases because of the gel. And then after the implantation of the needles, a new transvolumetry was taken, and the final adaptive plan after the adaptation of contours was calculated. So this is the real adaptation of the plans, and you see here in this case, for example, 90 needles have been implanted, and of course the shape, the volume of the prostate is a different one than before the implantation, and this is very important, this adaptation. Okay, the inverse planning process is an iterative multiple repetition dynamic process until the ideal situation is reached. And what we have changed in this protocol, we have defined by PSMA PET or by multiparametric MRI the DIL, the dominant intraprostatic region. And we aim, and you will see the dosimetry results for much higher dose here in the DIL than we have used to do it before. And this is a typical dose volume histogram, so the boost is high, anyway the dose in the prostate is high. Urethra can be saved, bladder and rectum you see here are bladder, neck, and rectum are at the same level, and before the gel, rectum was higher dose, clearly higher dose. And these are the first achieved results in the first 30 patients. The additional mean distance, prostate rectum pre-post procedure was at the base of the prostate 6.8 millimeters, in the midplane 4.5, and in the apex 6.3, and these were the total distances achieved. And we saw a learning effect, even in our group, which is really very experienced, especially in the midplane, not very pronounced, but at least 2 millimeters between the old patients and the first 10. But as you can see here, with advanced learning curve, so the last 20, the last 10 patients, this becomes very minimal. So in our hands, very fast learning curve. So the achieved dosimetric results were excellent. The D90 in all patients were above 105%, which is excellent. Very low mean doses in the rectum, and also D10 were 10% less than without the gel. These are the dosimetric results we have already presented during the last ESTRO meeting in Turin. Here are 20 patients treated, so high-risk patients treated with a combination of VMAT for the pelvis, so whole pelvis, and 2 fractions of image-guided brachytherapy, each 9 gray. The D90 was in mean 9.8 gray, so almost 10 gray. The boost was 12. See here the boost factor. D2Cs, rectum, bladder, and the 0.1 cc urethra were very favorable. In terms of EQD2, the total dose in the prostate, taking into account the external beam, was 112 gray, and the boost in the DIL region was 141 gray. You see here, rectum, bladder, urethra were relatively low doses. In the monotherapy, 10 patients, 30 implants, so 3 times 11.5 gray. We had D90 of 11.8, in the boost 14 gray, in the DIL region per fraction, and the prostate EQD2 was very high, 135 gray, and in the DIL region 185 gray, with quite low doses EQD2, 2 cc, as you can see here. And very important is we have not seen the same experience as our American colleagues made, no implantation related side effects according to the gel. So less than 20% of the patients reported very mild rectal discomfort according to CTCAA grade 0 to 1, this code. And we also couldn't see any kind of gastrointestinal toxicity so far in this cohort. So we have analyzed these scales. So our very preliminary results, according this modified protocol, KIL3, are very low acute toxicity, very steep drop of PSA post-treatment, so majority of the patients were in this category A of nadir PSA 18, so less than 0.5 nanogram per meter. So we hope that our longer-term results will fit to our long-term data. And just to give you the comparator, so we have analyzed the acute toxicity in the KIL3 protocol prospectively, and you see here that we saw diarrhea grade 3, sorry, this is German, but this is diarrhea grade 3, 2% in week 5, and grade 2, around 4% in the last 2 weeks of treatment, and grade 1, 42%. And proctitis, not grade 3, but grade 2, was 8% at week 4 and 4% at week 3. So we saw some toxicity, acute, and of course this toxicity had also impact on quality of life, which we also have published. And let me show you also a very brand new protocol we have opened 1 year ago, and this is salvage. for radio-resistant and recurrent in-prostate relapses, and local recurrences following radical prostatectomy. So the major tool to be used here was PSMA PET, which is a very nice tool to distinct those patients which are metastasized, so with oligomets or with multiple mets, and from those who are really just have a true local relapse without any other mets. And those patients we have retreated with brachytherapy. So, for example, in this case, a patient in category B, D, according to NPSA and RDPSA 18. So we didn't await it until these patients relapsed. We sent the patients to PSMA PET, and we saw that the relapse was in the base of vesicle seminals. And this case was a previous low intermediate risk cancer treated with HDR monotherapy alone. Of course, only prostate. And see here, this was the relapse region. We have reused the gel in this case, and this was feasible. And we have done that in several patients until now. Then we have implanted the gel. This is possible with the new online technology, so you can see your needles in live ultrasound, and you can push those really up to the tip of the seminal vesicles. This is a very nice technique. So we could retreat this patient very successful. And another example is the situation after a radical prostatectomy. You see here that prostate is not there anymore. You have the bladder neck, we have your urethra, and the deal in PSMA PET or in MRI. And this is possible in this case, implanted with 7 needles to reach in a radiation salvage situation, very good, reasonable plan. So in these patients, we have enrolled so far 21 patients, and we plan minimum 50 in those patients. But the reuse of SpaceOAR gel was easy and feasible, again, like in the primary. No grade 3 toxicity as far, some grade 1 and 2. And again, the majority of the patients had an adequate PSA response so far. So these results are, I admit, very preliminary, but this is what I can present now. So our conclusions are that the hydrogel implantation is very feasible, is not associated with additional procedural morbidity. It allows to create a distance between 7 and 12 millimeter, and this led to very much reduced hotspots in the ventral rectal wall and help us to change our strategy of implantation and to enhance the dose in the deal region. No grade 3, very low grade 1, some grade 2. And similar so far experience in the salvage situation. So thank you very much. So, I think, Brian, I think it's better you come also up to the micro. Any questions?
My question is, can you increase the dose in the peripheral prostate by using space gel in all the patients, or you are increasing the dose only in patients with a deal at the PSMA PET?
Yeah, our strategy right now, we try to increase the dose in all patients, in the peripheral zone. If we don't know, we have no knowledge about the deal, but if we have knowledge about the deal, we fuse the PSMA PET or the MRI with the live ultrasound and enhance the dose in the deal. Yeah, if this is our main target, yes.
We see the advantage, particularly with protons and doing hypofractionated courses, where we are not reliant solely on opposed laterals going through the femoral heads. But otherwise, we're keeping the doses very much the same with the goal of reducing any grade 2 rectal toxicity.
Sean Collins from Georgetown. We've placed about 60 spacers. I really like the fact that you talked about the practical radiation oncology article. When we get MRIs after our spacers, I think it's really hard to tell infiltration from pushing the rectum. I actually think it's more an artifact of the imaging, but I'd like to hear your comments on that.
Well, I leave it to our radiologists as well, but if you get on very high precision 3 Tesla sagittal imaging, you can see somewhere it appears to be in the rectal wall. Sounds like you have an interesting experience. I'm looking forward to the publication. If we get you up to Minnesota, you can teach us some things too.
Yeah, so our experience, as I showed you, is transcranial ultrasound. We rely more on this than on MRI. We do MRI also for the measurement, but we rely more on the measurement in transcranial ultrasound. I think if you do brachytherapy, it's no problem. You have this setup. If you don't have this in the department, of course, you have to rely on MRI only.
My interest would be mainly in the salvage setting. So you have treated some 20 patients in the salvage setting, but I guess quite recent after their primary therapy. Is that right?
Yes.
So are there any concerns for fibrosis that it might be more difficult to inject the hydrogel after 2 or 3 or 4 years?
Yeah, this is an important issue, I think, and that's why I think, as Brian explained, the hydrodissection as a first step is very, very important, because if you do the hydrodissection, you see you are in a fibrotic region and it's not going to work. You shouldn't attempt to inject the gel. No? But another point is the timing of the salvage. That's why we try with the Nadia PSA 18 to bring the salvage in terms of time, very close to the first treatment where the fibrosis is not very severe. No? So the case I showed you was treated 7 months after the first primary treatment. No?
Yeah.
So that's important, and also important is the first radiation technique used.
Yeah.
So if you have, the first technique was brachytherapy, low dose or high dose rate, is not that bad, fibrosis. Then if you have a pre-radiated IMRT or VMAT case where the entire region is fibrotic. But you're right, there are differences, and you have to be aware of that.
Yeah, once again, we have a handful of cases that are salvage cases, primarily external beam cases, and we've been able to hydrodissect. But that one case was a cryotherapy case that there is a little bit of a learning curve. But the important thing is, what are the consequences of mishap in one of the earlier cases, and the consequences are minimal, maybe some temporary patient discomfort, but they've all resolved. I know there's been some reports of fistula in literature, but I know that there's been over 12,000 cases done, and it's really a rare occurrence, and whether it's associated with the hydrogel is really a question of strong debate.
Yeah. So intraprostatic injection is not a big deal, because then, okay, you have a bigger target, then you have to treat a bigger target. But what should be avoided to inject the gel in the rectum? No?
My question is that do you have any other clinical experience of using hydrogel in some other site other than prostate? For example, I would say recurrent carcinoma cervix or any other pelvic malignancies.
Very limited experience at our institution putting hydrogel between a recurrent obturator lymph node and the bladder, but that's it. I think the prostate is always a good place to start with a lot of the new technologies because of the imaging and so on, but just very limited at our institution.
So with the hydrogel, we are not starting now to use the hydrogel to protect the prostate in rectal cancer. So in neoadjuvant radiochemotherapy for rectal cancer, I think this is an important issue, especially for younger men, but it's just a plan in the moment. We have used the Tracit, which is a marked hydrogel. It's another product in gynecological brachytherapy between vagina and the rectum, again to save the rectum, and we plan also to inject that pre-vaginal to lower the dose in the bladder in cervical cancer. And we are starting that program, but was not here the topic 6 months ago. And yeah, I hope next year we can report on this. Thank you.
Another small question. Once this gel is injected and you take about 6 weeks to complete external radiation, does the thickness remain same, or have you observed that it decreases over a period of time while the treatment is going on?
So we're not, at our institution, we're not imaging sequentially, but in some of the published studies it shows that there's a very minimal decrease of the gel. It's usually over 3 to 6 months, according to the published research, that it goes away.
So our program in combined external beam and brachytherapy is composed every 2 weeks of a brachytherapy procedure. So we have a live ultrasound every second week, and we didn't observe any differences. And we follow the patients in ultrasound, and the differences start to occur after 3, 4, 6 months. So for the first 2 months, is everything stable.
Thank you.
Welcome.
I have a question on dosimetry for seat implants. If you do the seat implant and then you inject the gel, you are changing the form of your prostate, and I think you're enlarging the place between the rectum and the posterior border of the rectum, of the prostate, but the posterior border of the rectum makes that your prostate is flatter. Does that change anything? Did you correlate the dosimetry?
No, in fact, depending on the level of the person who's doing, the level of experience of the person who's doing the seed implant, it provides an extra margin of safety, if you will, training residents in terms of where to put the seeds and how close to the posterior rectal wall, particularly in the apical region, because we do pre-planning, so patients will be in the dorsal lithotomy position, but when they're in the operating room, they're in extended dorsal lithotomy position, and if you're not watching the prostate too closely, you can put seeds too close to the rectum and the prostate, but if you insert the hydrogel spacer, then that offers a better margin of protection. But I haven't noticed any profound, to answer your question, any profound difference in the dosimetry.
Post-implant dosimetry.
Yes, change. We do the CT and the MR in the same day, and then we fuse the two, and then we use actually the MR to help identify the rectum and the spacer and fuse it with the CT, but there's nothing in terms of adverse consequences with the dosimetry. Hopefully that answers the question.
Yeah, thank you.
So we do the opposite in HDR, so first gel and then brachy, so it's no issue for us. But in some cases where the deal was your question, very close to the dorsal part of the capsule, we sometimes implant in the gel the needles. No? So we go 1, 2, 3 millimeters into the gel just to make sure that the deal is covered. Because we have space.
I can tell you at our institution we have patients that are actually seeking this out. They look it up on the internet and they specifically come to our institution because we're offering this as something very easy to explain to patients. And like many of you, I trained in an era where we didn't have image guidance. It was 3D to IMRT, and had a much greater experience in terms of managing rectal complications. And in certain respects, we're depriving our resident physicians of learning about rectal complications, but that's a good thing. And this just adds to it, depriving them more.
Yeah. So in addition, we have here in the room top specialist from Italy, for example, doing stereotactic treatments with the gel. Do you want to comment something, add something on top? Come to stage.
Thank you. Only to add some comment. As you said, I think that SBRT is an emerging issue, and I think that if we use very high dose per fraction, the SpaceOAR could be helpful to reduce the dose to the rectum, especially for late potential side effects. But I think also that we can use for other settings, specific setting, could be, for example, retreatment in prostate. You know that this is an increasing phenomenon. We can use brachytherapy, we can use SBRT, and if we avoid to retreat again previously organs that were involved by the first course of radiation therapy, could be a good opportunity. So I think that these indications are enlarging the possibility to use this kind of tools, or for example trace it in pancreas or in breast. I think that there are a lot of incoming issue and news that could be helpful for our daily work. Thank you.
Thank you. Yeah, actually, yesterday we have discussed the possibility of a randomized trial in, to compare different modalities of monotherapy, no? LDR, HDR, stereotactic treatments, and protons. No?
Yes.
So, as a European-American joint.
I'm very excited to hear that people are using this to protect the prostate from the rectum, because as I tell many of my resident physicians, the prostate is one of the most important organs in the body. And on that...
It was actually the idea of the surgeons, because they were aware that we are doing that regularly in prostate cancer, and say why we shouldn't use it to protect prostate in rectal cancer. Makes sense.
So I don't know if we're out of time. We've had a lot of great questions. I certainly thank everyone for attending, and Dr. Galalae, and of course thanks to Augmenix and for developing this product that we have certainly found to be useful. Thank you.
Thank you very much, and give our colleague from America a big applause.